Good morning, good afternoon from wherever you're joining us today for week 3 of our HIV Prevention and Education Summit. My name is Dr. Tashina Reeder, and I am glad that you decided to take your time during your lunch hour to join us to hear all about today's presentation entitled Hepatitis C Care During the Times of COVID and Beyond. So before we jump into today's webinar, there are a few things I would like to share with you. First thing is that our chat box rather, has been disabled. So you will not be able to use the chat box to communicate with us. However, we may communicate with you in the chat box, but you can use the Q&A box to ask all your questions. If you're asked a question, you can put it, your response is all in the Q&A box right below your screen, okay? At the end of the webinar, don't log off. You'll be prompted to complete a survey. We want to hear from you and for you to share your feedback regarding today's presentation, okay? If you have any questions, remember, use the Q&A box because the chat box is disabled, okay? So without further ado, I'm going to pass over the presentation to our presenters, Alex Ripkin and Lora Magaldi.
Thank you. Thank you, everyone. I'm going to share my screen. Hope this works. Laura, can you see that?
I can, perfectly, thank you.
Okay, thank you. Hi, everyone. My name is Alex, and my colleague Laura and I are here to speak with you about hepatitis C care in the age of COVID-19 and beyond. We are, I think, at this time still in COVID-19 era, but we're able to see glimpses of the beyond and prepare for the beyond. But what we'll discuss in this presentation is all the things that we were able to learn and implement that actually make care better for our future of Hep C care at Philadelphia Fight and elsewhere. We have a couple of objectives we'd like to go over. The first is we're going to discuss safer protocols and alternatives to rapid community testing for Hep C. We're going to discuss remote patient linkage and navigation strategies that we were forced to implement due to not having access to patients in person like we've been used to and have built our program around for many years. And we'll also discuss the importance of implementing and supporting Hep C telehealth at both inpatient and outpatient community partnering sites. And we will talk about lessons learned and future goals of Hep C subspecialty care, both within our own clinics at Philadelphia Fight and elsewhere.
Alex, I'm not too sure if you advanced the slides to the objectives. I'm still seeing the title page.
Oh, really? I did advance to it. Let's see. Thank you for helping me troubleshoot there. Oh, you know what I did? I changed, I moved it to the screen in front of me. You can see it now, right?
Yep, I can see
Okay.
the objectives.
Then everyone already heard these, so I'm going to advance to the next slide that you can see now, right?
Yep, perfect.
Okay.
Thank you.
Thank you. Sorry about that, everyone.
So See a Difference came to Philadelphia Fight in September of 2016. We were previously established at Drexel University and we're working in the community with PHMC and Babashi, and then a little bit of work both at Drexel and Hahnemann. So when we came to Fight, we really wanted to ensure that cure was available at Jonathan Lax, at John Bell, Broad Street Ministries, and YHEP for our younger patients infected with hepatitis C. And we also wanted to establish community-based testing at drug treatment programs, homeless shelters, medication-assisted treatment. We used to work in senior centers and do a lot of health fairs and church fairs where they were doing HIV and then hepatitis C testing. We wanted to be sure that all of our Fight clinical locations were testing all of our patients. And in 2018, we began making sure that everybody who was eligible was tested at the Philadelphia Department of Prisons up on State Road. We used to only test people who were sentenced and were leaving jail, and now every person who comes through intake at the jail is tested for hepatitis C along with their HIV test, their STI test, and their other basic screens. Next slide.
So hepatitis C is a liver infection caused by the hepatitis C virus that is spread through contact with blood from an infected person. So there are multiple sources of infection for persons with newly diagnosed Hep C. The source with the highest rate is injection drug use, which can come from sharing needles, syringes, other equipment used for injecting drugs. The next proportion is sexual contact. Oh, it's moving without me. I'm sorry, guys. I'm going to keep an eye on that. Sexual contact. The next is a blood transfusion that happened within the hospital system prior to 1992, before they introduced universal precautions within the hospital system. And then a lot of people have an unknown source of infection. And in the other category is possibly birth. I believe 6% of people who were born to an infected mother did contract the virus, or it was transferred to the baby. And then there are some other things like healthcare disclosures, and a lot is unaccounted for. So it's hard to say, but we know that, we know that not every Hep C infection is accounted for. So we know that the amount of Hep C that is counted is not the actual amount, which Laura will get into with the epidemiology in a couple slides. So there are two types of hepatitis C. First is the acute infection, which is a short-term illness affecting some people, so it's less than half of people. And then chronic infection is a long-term illness affecting more than half of people who become infected. And chronic Hep C can result in serious, even life-threatening health problems like cirrhosis and liver cancer. And cirrhosis is, so there's fibrosis, which is a fancy word of saying scarring of the liver, and cirrhosis is really severe scarring. And liver cancer is caused by many things, but Hep C is a big source of the cause of liver cancer. Let's see. So many people don't show any symptoms, and so they don't know that they're infected, which is why a lot of people, but the longer they have chronic Hep C, or that their acute infection turns into a chronic Hep C, the more fibrosis and potential cirrhosis they might have on their liver and other extrahepatic manifestations, which is a way of saying that Hep C has an effect on the whole body, not just the liver.
So hepatitis C is the most common bloodborne infection in the US. We do know that at least 3.2 million people, but probably closer to that 5.2 million people are chronically infected with hepatitis C. And the reason for that huge gap, like Alex said, a lot of people who have it don't know that they have it. And also the studies where they count seroprevalence in the United States don't really count the most marginalized people. So it's not counting people who are homeless, people who are undocumented, people who have Medicaid or Medicare. They're really just capturing those like middle American, middle class people who have pretty good health insurance. So we do, when we do education, we do say, you know, let's say that there's 5.2 million people who are chronically infected. Here in Philadelphia, we have anywhere between 45,000 and 50,000 people who are chronically infected in Philadelphia. As you know, this is a hub for opioid use. And because that's the most common way of getting sick with hepatitis C, that number is in flux. So again, we overestimate 45 to 50,000 people. The birth cohort is the the part of the population with hepatitis C who were traditionally the easiest to treat, because most folks do have Medicare or they have private insurance where they could start getting treated pretty easily when the direct acting agents or the medicine that works really fast to cure your hep C was released. But those born between 1945 and 1965, about 3.27% are antibody positive, and there is racial disparity there. Non-Hispanic Black folks, about in the birth cohort, about 6.31% are infected with hep C, non-Hispanic whites 2.92%, and Mexican American and other are 2.78. Again, 50 to 75% of individuals who are chronically infected with hep C are unaware of their infection. A lot of the people that we see out in the community have a pretty good idea that they may or may not have been exposed, but until you get properly tested, you can't be sure whether or not you are chronically infected. Next slide. The CDC says that all individuals over the age of 18 should be tested at least once for hepatitis C. So everybody here listening should at least have one complete hepatitis C test performed. That means an antibody test, which lets you know whether or not you were exposed to hepatitis, and also a viral load test to see whether or not you have virus in your body. If your doctor hasn't tested you for hep C, or if you're not comfortable asking your doctor for a hep C test, you can contact us. Our contact information will be at the end of this presentation, and we'll get that all taken care of for you. Everybody who has a hep C risk factor should be screened at least annually. Some of our folks that we see who are negative, we ask them to come back in 3 months. Some of our patients get tested every single time that they come to the doctor. We want to make sure that anybody who is infected with hep C gets treated as soon as possible, so they're not at risk for liver failure and cancers and fibrosis and all that stuff that comes along with being undiagnosed and untreated. Next slide. Primary care providers should follow CDC guidelines for testing even in a pandemic. One of the hardest things for a lot of primary care providers was getting labs on folks, especially with telehealth medicine being practiced, because you have to leave your house, you have to get to LabCorp, you have to make sure that all those lab orders are following you to wherever you're getting your blood drawn. So it was tricky, even here at Philadelphia Fight, to make sure that everybody who was seen by a primary care provider was tested for hepatitis C and other routine blood work. For those who cannot or do not seek primary care, we want to make sure that we have plenty of community-based and jail-based screening programs available for those who are really at greatest risk for hep C. Here, we've worked to ensure that all Fight patients at all of our clinics that were listed before, all of the incarcerated individuals in Philadelphia, and people who are entering specific recovery programs continue to be screened according to those guidelines, while keeping everyone's safety in mind. For everybody who's not falling into those populations, we did get a little bit creative in what we did this last year and a half. As most of you guys, or some of you guys should know, rapid testing can take place in about a half an hour. That's that finger stick test that looks a lot like a HIV test. It's done face-to-face in a really close space. The tester and the client are, even though that they're together and we need a private space to test, it's not always quiet and it's not always perfectly confidential, because especially if you're in a residential setting or even a health fair, people can hear through the walls, or people can hear through the little screened off area that you have. So a lot of times you're like whispering and you're talking really close face to face. Even when you're in full PPE, both of you, it's still really uncomfortable because we're in a pandemic and it's not comfortable to be close to another human. So our answer was really just to directly link people to subspecialty or primary care for anybody who knew that they had hep C, or anybody who suspected that they may have been exposed to hep C. Next slide. We also really worked to create flyers several times throughout the pandemic to let people know exactly what we're doing here at FIGHT. So we took that printed material and we took it out to our partnering sites. We educated FIGHT staff about what to do if somebody mentioned Hep C or asked about Hep C services. And we made those direct referrals to a FIGHT provider whenever possible. So if we were out in the community and somebody's like, "You're that Hep C lady," I'm like, "Yep, let me get you an appointment right away." A lot of our team members carry around an iPad that can directly connect to our medical record, and they can schedule an appointment. So there wasn't that like sitting and whispering really close face to face with anybody. We just said, if you think you've been exposed or if you know you've been exposed, let's just get you into a doctor. And we can usually do that within about 72 hours. Next. Here at FIGHT, our providers screen for Hep C, HIV, other STIs, and of course, like regular blood work that any provider would take on a regular routine visit. If a patient tested negative for Hep C, they were offered continued primary care services, supportive services like subspecialty care for other conditions they may be living with, behavioral health support, medical case management, dental care, re-entry programming, and everything else that we offer here at FIGHT. If a patient tested positive for Hep C, their subspecialty care began immediately at that very minute. And our team would mobilize to make sure that the pharmacy stuff is getting taken care of, the case management stuff, any other supportive services around their basic care for Hep C. The next. On this slide, I just really like it. I think it really reflects the importance of the work that we do, not only in the clinic, but also out in the community. It talks a little bit about those baby boomers, our folks born between 1945 and 1965, who are about 75% of all of those living with Hep C and 78% of the deaths that are attributed to Hep C. We know that the Hep C prevalence among people who inject drugs, that's that PWID, is estimated to be up to 77%. So we want to make sure that we are where folks who are injecting are. And again, that means if that means going out on the street, that means going out on the street into the recovery houses, into homeless shelters. We know that Hep C prevalence is higher among HIV positive men who have sex with men than it is in the general population. We certainly know that it is very prevalent in jails and also among migrants and people who are coming from countries where it's more prevalent. So we serve every single person here. It doesn't matter if you're documented, undocumented, if you have insurance or you don't. If you are a person with a pulse, you're eligible for services here at FIGHT. Next.
I'm going to talk a little bit about treatment for Hep C. Treatment is recommended for all patients with chronic hepatitis C infection. That means that everyone who has tested positive for hepatitis C and then has a Hep C viral load and has been diagnosed with a chronic infection. Medication for hepatitis C is very different than it was a decade ago. And so a lot of people have misconceptions about Hep C treatment, which is why every time we have a chance to get on a webinar or in front of a person to talk about Hep C treatment, we talk about it. And so medication is now 8 weeks or 12 weeks, the majority of the treatments, and they have very, very few side effects. And they are, so a lot of people might have heard of the medication called interferon that lasted close to a year or more and had many side effects that affected people's entire lives. And so that is not happening anymore. There is no shots or biopsies. This is in pill form. And these are the medications called direct acting antivirals that attack the virus in your body directly. So that's why it has very little side effects. The medication is more than 90% effective if taken in its entirety. And we work with people to take it in our clinics with direct or daily observed therapy, DOT, with our pharmacist. And we also deliver medication and we also communicate with people throughout their treatment to make sure that everything is going well, especially if someone does experience any sort of side effect. we'd like to treat the side effect that might be nausea or headache with something, and in order to allow someone to continue the treatment entirely. Even during regular times, so the before times is what it's been called in many cases. So when I say that, I mean before COVID, early 2020. We know that patients may have had several barriers to Hep C care. We know that because we were working to address these barriers for many years. The See a Difference team and Philadelphia Fight, as well as a lot of our partnering organizations throughout Philadelphia and across the country, truly. Some patient barriers to Hep C care include comorbidities. So a lot of people might feel like they have other health conditions to take care of, and they might not prioritize hepatitis C, including competing priorities in their health conditions, but also competing priorities in their life. They might feel like they need to get housing first, or they need to do something else in their lives before they feel like they're more stable enough to sit down and take medication. There's a lack of transportation as well, and we try to limit that barrier by providing transportation. I almost said tokens, but I guess we're giving out cards these days too. There was and continues to be a limited knowledge of hepatitis C and a stigma around Hep C, and those two often continue kind of in tandem. The other day, I was talking to a patient who has known that she's had hepatitis C for 10 years. And until sitting in front of me, she thought that she needed to be not using drugs for a period of time before starting hepatitis C treatment. And so I think that combination of lack of knowledge and stigma, or, she got that information from someone, right? Or that didn't come out of nowhere. And I think stigma really reinforced that continued feeling that a person is not able to get treated if they're using certain drugs or any drugs. And that is simply not true, especially in our context. We treat everyone regardless. In many cases, I'm not going to say in all cases, but in many cases, drug use is not a reason to not treat someone, especially in our clinics. And a lot of people who might need treatment for hepatitis C have had prior negative experience in healthcare settings, which I think also feeds into the stigma around Hep C, stigma around drug use, stigma around racism in the healthcare system, stigma around having experience in incarceration, and many other things too. There are also provider barriers to Hep C care. Working in the clinic, I've noticed that, in other clinics, I should say, that there's a perceived lack of value in treating some patients. So we've heard from other providers that if they're using drugs, they're going to get reinfected anyway. This person I spoke to actually had this fear that I'm just going to get reinfected. Am I allowed to get retreated? And the answer is yes. We do have the ability to retreat someone. So there is value in treating someone, especially because we're able to treat them again. There's concerns about adherence. Can someone who is potentially using drugs adhere to a medication? And to that, I've heard many of our providers say yes. In fact, they're able to dose themselves daily with another type of drug. We believe that they can also adhere to this daily medication. Some medical contraindications are present, but nothing that can't be solved and collaborated upon with a pharmacist and with a medical provider. And then we have competing priorities too, and limited time. You might have a patient in front of you who, they're right there. It's hard to, engage them for a longer period of time because that patient has competing priorities. And Hep C treatment does take 8 to 12 weeks. I'm familiar with the systematic barriers to Hep C care working in the program. Insurance access is less of an issue than it used to be. It is insurance access now. Everyone with Medicaid does have, and most Medicaid, I would say all Medicare plans have Hep C covered by their insurance plans. And most people are insurable. There are people who are uninsurable for various reasons. And that is kind of like, I work with our pharmacist, Melanie McCoy, very closely, and we work on a lot of those kind of special projects to make sure that someone has access even if they don't have insurance. But most insurances do cover Hep C treatment. completely. The issue with that, even though they do cover them, is that there's a really rigorous prior authorization process that we need to go through, and that has gotten easier, especially in Pennsylvania, as they've lifted restrictions, as I'll get into in a couple minutes. But there is a whole prior authorization process. There's not the ability to, so with normal prescription medication, doctors or prescribers can write a script and a person can take it to a pharmacy. With Hep C treatment, you can't do that. A prior authorization form needs to be filled out and needs to get approved by the payer. And so there are payer restrictions for Hep C approval, and State of Hep C is a website that will show you that there are different approval ratings and approval standards across the country. There are payer requirements. So that's kind of with, they require certain people to have different levels of sobriety, different levels of sickness. So you need to have a certain level of fibrosis. And then there are healthcare silos, which is a systematic barrier that we're always trying to break down within our clinics and also within our partnering agencies, where we really should be collaborating more as opposed to working in our own groups. Laura, is this?
Sorry.
Okay.
I had muted because there's a little bit of noise outside my office. When we started to shut things down early in the pandemic, and we told our testers that testing and sitting with close to close face to face with somebody for a half an hour wasn't a really great idea, they immediately said, well, I can't not do anything. So our testers again shifted to doing this direct referrals, and then immediately our testers became like patient navigators and linkage coordinators and everything it took to stay in close contact with not only our patients, but also our partnering community service providers. We always have an internal champion at each of our site, and that's the person we can call for anything, no matter what. So we stayed in really close contact with those folks, made sure that if that person wasn't answering their phone or they left their position because of COVID or anything else, that we would call their supervisor and everybody over top of them, everybody underneath them, and just let them all know that we were still here and that we were doing everything in our power to be sure that our shared patients are getting taken care of. The clients and patients or their representatives, so say their social worker, their case manager, their mom, anybody can call our office and schedule an in-person or telehealth visit for Hep C or anything else. Usually within, we can usually get folks in within 72 hours of that phone call. Next slide. Our entire team, again, our testers became linkage staff for the last year and a half. They would perform well checks with our patients. We'd say, hey, how are you doing? We haven't forgotten about you. What do you need? And how can we get that for you? We would visit people at their homes, visit people at their sites if we were allowed in. We were doing checks for folks that are incarcerated. We would see them at the jail or talk to their social worker at the jail. Again, just letting people know that we were here for them, making sure that they were doing okay throughout everything that we've all been through this last year and a half. Street outreach has always been something that we've done. Just by nature of getting off the L and going to a partnering site, we can run into folks that we serve. But we also did some intentional street outreach, both here in Center City and out in the most vulnerable neighborhoods where we know that our folks are hanging out, letting them know again that we're here, we haven't forgotten about them, and that we can help them with a whole bunch of stuff. And then we also have a really good working relationship with the Philadelphia Department of Public Health hepatitis surveillance team. So if I can't find, or our team can't find somebody, I can pick up the phone and say, hey, have you seen anything come through for Tom Smith? We can't find him. And they'd say, oh, let me check. Oh, he did have a viral load run in the last 6 months, or it looks like he's negative, so that's good. It's just really, really has been so valuable to have that working relationship. And of course, we have all of our contracts set up so we can do that. Some data sharing and some collaborative navigation. There are a few few patient navigators who work at the Department of Public Health who we stay in touch with pretty regularly. So if folks did get lost to care with us, it'd be really reassuring to know that they have found care somewhere else, or that they're on the case too, and they're also looking for that person. Next slide.
We had to get really creative this year with our treatment. And so care has always been individualized to the person. A patient is always meeting with their one provider throughout their entire treatment and getting direct care from our pharmacist and our case management and linkage team. But this year felt like we really geared it up in terms of meeting the patient where they were. From the beginning, like Laura mentioned, we were reaching out to people for well checks to check in with them to see how they were doing. And we were not wanting to stop treatment for anyone, or even stop the flow of treatment if someone had, the prior authorization process started, or if we had medication in our clinics for them. We just wanted to keep going. So I remember from like the get-go of like mid-March of last year, we had to put strategies in place to find people and deliver the medication that we actually had in our offices to them, so that there was no break in any sort of treatment. And then moving forward, since we weren't able to see people in our offices, we had to get really creative with telehealth. And thankfully, early on in the pandemic, they allowed for telehealth to be billed by insurances. So we were able to, within all of Philadelphia clinics, and I imagine across the health centers in the United States, we were able to implement telehealth, whether it was audio or by video, for patients who were existing patients, I think prioritizing those people, and then really providing telehealth services to people who were new patients, so that there was no gap in care for anyone. And so we had telehealth, we had mobile phlebotomy. So we sent out our phlebotomists as part of our See a Difference team, and our, I think the majority of our phlebotomists that we did send out were from the See a Difference team, and they went to some of our partnering agencies such as Kirkbride and Self Help and Durham Medical Center. Like I said, we had medication delivery, whether it was the middle of the treatment, or what we had never done before, which was start a patient as a telehealth person, go through the process without ever having, seen them in person, and then actually deliver their first medication, first month of medication. And remember, I said it's either 2 or 3 months typically. And so there is a lot of coordination that needs to happen with delivering medication and then tracking to see when a next delivery is available. And I think at that point, we didn't know how long this would really go for. And so we were like, all right, let's just get this first month out and commit to getting them the rest of the medication, no matter what it was. But for the entire year, we just continued to do medication delivery, and our team really stepped up to, every single person was a medication delivery person throughout the entire city. And that included 2 people's houses. And that included 2 substance use treatment centers where they were doing direct, not necessarily observed treatment, or observed therapy, but direct dispensing, possibly with other medication like methadone. We also did a lot of follow-ups virtually, and now we're able to start to see people. Over the year, we were able to increase our capacity within the clinics, but we continue to do virtual treatment, which actually, it's amazing that it's now implemented, because it really allows us to reach people who wouldn't have been able to come into the clinic, or didn't want to be seen in person for a variety of reasons, or didn't want to ride the subway for certain reasons, and just it decreases a barrier to have them stay at home and do a visit and continue being on their medication, as opposed to holding their medication and waiting for them to come into the clinic, which they weren't able to for a variety of reasons. We still have some gaps in care. I think we will always have that. But this has really allowed us to implement protocols and practices that I think we'll take with us, and I'm hoping that they will continue to count telehealth so that we can continue to do it too. In addition to what I just mentioned, we have, I don't think we've mentioned what a fiber scan is yet, but basically it's a small ultrasound machine that is able to be used to detect the stiffness or the scarring of the liver. And we have within the See a Difference team and for Philadelphia Fight, a mobile fiber scan. They're not all mobile, so we're really feeling lucky that we get to have a mobile one that we're able to carry around in a suitcase looking thing to various programs and across our clinics. And that has allowed us to access a lot of people and really assess their liver health. And to supplement our telehealth visits, as opposed to individuals needing to have telephones or when they're in an inpatient program, they might not have those tools. We actually were able to provide iPads to our 2 largest community partners. I think I mentioned Kirkbride Treatment Centers and Self-Help. And those sites were able to, whether we as See a Difference staff members were on site, or we were able to collaborate with the staff at these programs to, put a patient in front of a monitor, and we were able to have televisits happen like that. Our patients had access to all services provided at Philadelphia Fight, especially at John Bell Health Center and Institute for Community Justice that Laura is going to mention in a little bit. Here's an overview of so many things that John Bell Health Center can provide. It truly is a very inclusive primary care health center that includes practitioner examination, medical history, diagnostic testing, age-appropriate cancer screening, of course, routine screening for sexually transmitted infections, HIV, Hep B, and of course, Hep C, and screening and preventative care for diabetes and hypertension. We do mental health screening and referrals. I see our BHC as one of the attendees today. Smoking cessation, referrals for specialty care, cervical and breast cancer screenings. We have case management for our patients. And we have community health worker services. Oh, and here's our behavioral health consultant. And lots of prep, pre-exposure prophylaxis, counseling, and assistant program services. The John Bell Health Center provides a safe space for people to access culturally competent, comprehensive primary medical care, truly regardless of the individual's insurance status, ability to pay, or life circumstances. And this has been we've really seen this play out over the past year, especially as we've engaged people just continuously, and people who we thought would fall off have not. And we've really remained a community of medical providers, case managers, linkage staff, and our patients have really been at the forefront of our mission. I think
sorry, you guys, it's loud over here. A lot of our patients do cross over with our Institute for Community Justice Center, which is right below us on the 2nd floor of 1207 Chestnut Street. Services there include re-entry programming like education stuff, community and civic engagement, advocacy. We have our prison linkage specialists who provide linkage services for medical care, court advocacy, health education, and social service support, and then also discharge planning support to just help people land back on their feet once they've been incarcerated. We want to make sure that they have a smooth transition once they come home. Next. This is our team. Like I mentioned before, everybody who has the word tester after their name, really, they do everything. All of our care coordinators and our medical case manager and our patient navigator, they can all test people. All of our testers can do all of that other stuff. We really have something special going on here, I think. And that's how we've been able to get through this last year and some months, just by working together and putting everybody's healthcare and best interest at heart. So I can't say enough good things about every single one of these people whose faces you see. If you need to reach any of us for anything, our phone numbers are all there. Those are all direct lines. Don't be afraid to reach out. We're here for anybody, for anything that anyone could possibly need. That's the end of our presentation. I want to thank Alex. I'm sure that there's questions to be answered. And this is Alex's information and my information. It's a little bit more detailed. Our email addresses are there, our phone numbers are there, and then our position titles. Thank you.
Thank you, everyone. Thanks, Laura.
Thank you so much for your presentation. It was very informative. We do have a question in the Q&A box. So while we prepare to answer this question, for those of you who are viewing, if you have questions, please feel free to put it in the Q&A box so we can answer the questions you may have, okay? So there's one question states, can you speak more to how individuals on Medicaid would not be captured accurately? Medicaid has significant amount of reporting and monitoring for Hep C claims, data and treatment that is tracked by the state of Pennsylvania.
Oh yeah, I can definitely answer that. Yes, they do now. So when I mentioned that, that was part of the study saying that like 3.2 to 5.2 million people are infected with hepatitis C. That was done, I think it's 2006. It's in the 2006 by NHANES. That's the National Health and Nutrition Examination Survey. So they weren't really truly polling from every source of hepatitis C testing. Back in 2006, there wasn't comprehensive testing the way that there is now, where you would go to your doctor and it would just be part of your panel. It was pretty specialized testing for people who maybe were having liver failure or had shared that they had a risk factor. And then the treatment back then wasn't so easy. Like Alex spoke about the biopsies and the injections and the special diet and the year long of a really adverse medication treatment. So it was not as comprehensive as it is now. So thankfully now Medicaid, the care that you get when you have Medicaid is comparable to the care that you would get with a private healthcare insurance in most places. And then the other thing for everybody, I think, who are hesitant to be tested is some of the things that Alex spoke of, those patient barriers and those provider barriers. Sometimes people are really embarrassed to tell their provider that they're at risk for hepatitis C, or it's the same doctor that their entire family sees or they've been seeing since they were a child. And it's just not easy to open up and say, hey, I've been using injection drugs and I think I've been exposed to hepatitis C. We all kind of go to the doctor and be like, no, I'm good. No, no unhealthy behaviors. Everything is totally fine. And then just the way that folks were treated in the past when they did open up about some of those things. I think that people do avoid the doctor sometimes, no matter what healthcare insurance they have, especially if they have a whole lot of other stuff going on. They take care of their children first, their housing first, their other needs first, and then they'll get to the doctor. I hope that answers the question. So basically it was a long time ago. People weren't being counted the same and people weren't being treated as equitably as they're treated current day.
Thank you for the response. There aren't any other questions in the Q&A. Again, if you're viewing this, you can ask your questions if you have them and put them in the Q&A box at this time. In the meantime, are there any last words you may have, Laura or Alex, before we close out?
No, I think just, give us a call if you have any questions. We're always at the ready. We're taking new patients. We're happy to answer any questions. We didn't get too much into how you get hepatitis C and what happens exactly when. We really wanted to give the message of we're still here. We're still giving everybody what they need, and hopefully folks have some takeaway messages of what really worked in a pandemic that we want to take forward.
Okay, we do have a question we just received. It states, is there a frequency you all screen for patients who have risk factors, or if they have been treated but still may be at risk?
Sure, we want folks that are at risk to be tested as often as as often as their doctor feels or their provider feels necessary, or as often as they feel comfortable. So some people out in the community know where to find us, and we will test them once a week for as long as, if somebody feels like they're in crisis, or if it makes people feel better to get that test, then we will certainly test them, not every day, of course, but there are folks who have come to us weekly to get tested. Some folks who get tested every 3 months, some folks who get tested every year. And it is certainly the case that people can be treated and reinfected. And part of the message that they get while getting treated here at FIGHT is, if you ever feel you may be exposed, come back and we'll test you and see if you need to be retreated. People can get retreated here at FIGHT. We'll treat you 1,000 times if it's necessary.
Thank you. Another question, what are the symptoms of HCV infection?
Do you want to take that one, Alex?
Sure. So someone might not feel symptoms for many, many years. And that is a reason why a lot of people don't realize that they have Hep C until they go to the doctor and get a fiber scan or start to feel these symptoms. One of the symptoms is jaundice, where your skin might turn yellow just because your liver isn't working as it should. Maybe some fatigue, headache, feeling like there are some people have expressed that they might feel depression with hepatitis C. I'm picturing a whole slide that we had on like a Hep C 101 that I wish I had queued up, which talks about all the different areas of the body that Hep C really affects. But Laura, what am I missing here? I think those are the main ones.
Yeah, that's the most, some people might feel like they have like flu-like symptoms. I think we're all sort of experts in asymptomatic viral infections after living through what we've just lived through with COVID-19. Sometimes people feel nothing. Sometimes, like Alex said, a little bit of a headache, a little bit of unwellness.
And it's persistent. It's not just like something that like comes up the moment that you're infected, and it doesn't necessarily pass as much as like a flu passes. And actually, we have a lot of people who will say that they feel much better after taking the medication. And that's just from symptoms that they didn't realize they had. So they feel like they must have a much clearer head. They don't have as many headaches as they did. And so it's pretty amazing because the symptoms that they didn't even realize could be attributed to Hep C end up leaving their experience once they do have the treatment.
We hear that a lot. Yep, I didn't know I was feeling so crappy until I got better.
Thank you for answering that question. I'm sure that's a common question you all receive from folks. Well, it looks like there aren't any other questions remaining. And so with that, we will close out. For those of you still with us, don't log off. When this webinar ends, you will be prompted to complete a survey. So please fill out the survey so we can hear from you and your experience of today's webinar. Thank you for attending. Thank you, Alex and Laura, for presenting. Everyone, have a great rest of your day.
Thank you, everyone.
Bye-bye.